Welcome to Ideas in Action, the official University of Southern California podcast. This show was recorded live on USC's campus.
Welcome to USC's Facebook Live. My name is Lee Hopper and I cover science for USC. My guests today include microbiologist Paula Cannon, who's been educating Los Angeles about how COVID spreads and pretty much every question you could think of. Our next guest is Susan Butler-Wu. She's also a microbiologist who knows everything there is to know about COVID testing. Rapid testing, PCR testing, false positive, false negatives, kind of the promise and limits of testing. We also have Dr. Ali Gholam-Reza-Niad, who's given me permission to call him Dr. G. And he was diagnosing COVID before we even had tests via chest x-rays. So he has a unique perspective on all this. So thanks for being here, you guys. Would you agree that scientists have responded to coronavirus with amazing speed?
Yes.
Can you talk a little bit about that?
We've had to give up our day jobs pretty much, or acquire a second one. I'm sure I'm speaking for my colleagues. From like the beginning of March, I run a research lab, and normally we study HIV. But from March, we also took on, we just pivoted and we started working on the coronavirus straight away. And it's been exhilarating. It's been exciting. It's been amazing how much collaboration we've seen. The normal barriers maybe between different scientists, the competition, all gone away. People are sharing information, sharing reagents. I wish it could be like this all the time. It's actually been really great.
So Dr. Cannon,
I would just like to say, I hope it's not like this all the time from the diagnostic lab standpoint, because we've risen to the challenge, but it continues to be a nightmare. So
good point.
I appreciate the collaboration for sure, but it is still challenging for us in the lab, clinical lab.
Can I just add one more thing? I think over the last 10 months, there were more than 60,000 publications on coronavirus, COVID-19. That it's something very, very unique about this disease in the probably entire history of science. In 10 months, 60,000 articles is something that I think never happened before.
Mm-hmm. I think you're right. Well, I wanted to focus on how far we've come in such a short amount of time. And I thought we'd start with Dr. Cannon talking about how the virus is spread. A lot of people will remember when it first started out and we didn't know a whole lot. There was a lot of emphasis on, say, closing down playground structures or keeping your groceries sanitized. Paula, can you talk a little bit about where we started and what we know now about how it spread?
Sure. So again, I think everybody can remember back to March when you couldn't buy Lysol wipes anywhere. Hand sanitizer was running out. And there was definitely an emphasis, and maybe a little overemphasis on things like, are my Amazon packages going to give me COVID? How long do I have to keep them quarantined before I can bring them into the house? And do I need to wipe down every can of tomatoes with a Lysol wipe before I can use it? And I think we've sort of moved on a little bit, and we now understand that while the virus can certainly be transmitted through surfaces, if you touch them and then touch your face, you can get infected. I think we're increasingly understanding that the dominant way this virus is spread is person to person in close proximity without people wearing masks. So it's basically you're breathing in the virus that somebody else is emitting from their nose and their mouth, which is kind of gross when you think about it, but it's what we humans do. We kind of leave a little trail of kind of mucus and saliva around us. And so that's why the recommendations are still to wash your hands, be mindful about what you touch. But increasingly, what's going to protect you is if we all wear masks. It stops an infected person spreading the virus into the air, and it stops other people breathing it in. And then, of course, we also keep our distance. So again, we're thinking about being outside that kind of COVID mist that other people are generating.
And then indoors versus outdoors, what can you talk a little bit about that?
Sure, and I think it's sort of common sense when you think about it. So again, if you have this model that an infected person is breathing out droplets and mist containing this virus, then if you're outdoors, you know that first of all, the sky's the limit, there's no ceiling, and there's, turbulence and air currents, and so that virus will get dissipated very quickly. If in contrast you're indoors, in a smaller space with no ventilation, then as you are producing the virus, it's going to hang around. And so even if somebody is maybe sitting 6 feet away from you, over an extended period of time, your little cloud of virus is going to make its way across the table. And that's why, here in California, we don't allow indoor restaurants, indoor dining, because it really presents a hazard.
Yeah. Okay. Thank you. Dr. G, can you talk a little bit about what you see in the hospital and how at the beginning we thought that serious illness was mostly pneumonia, and our understanding has come to be that it's actually a lot more complex than that, and there's a lot of lingering symptoms that we also worry about.
Sure. Well, the very first reports of COVID-19 from China was just presentation of pneumonia. I remember it was January that I published my very first article. At that time, there were not that much publications out there. So we tried to collect some information from similar coronavirus family infections. We compared limited data of COVID-19 with the past experiences of SARS and MERS. And what we concluded was that SARS and MERS can have manifestations in other body organs. I mean, like in the belly, in the brain, everywhere. But COVID-19 mainly involves the lung. Why? Because we didn't have that much information. There were like few publications out there. It was less than a couple of months later that we found, we were wrong. So we corrected ourselves. We said COVID-19 can actually involve almost every single body organ. There were a lot of reports from different countries that people presented with different symptoms, presented with a stroke, belly pain, like conjunctivitis, eye redness. And then they evaluated the patient and found that the main reason is COVID-19. What we saw, like I personally, it was in March that we saw a lot of cases who came to the emergency department with belly pain. So the emergency doctors did CAT scan from the abdomen, from the belly, and incidentally, we found pneumonia in the lung bases. So gradually, we found that COVID-19 can first attack every single body organ, and then we found that there is a kind of diffuse inflammatory response in the body that can affect all the different body organs.
So I think you also mentioned how you would have people would come in and you would do an X-ray to see what their lungs looked like, and you would see maybe there was no lung involvement.
Yes. There were few cases that we found in March that the patient had nothing in the lung, and they mainly presented with belly pain. And later on, there were some publications, scientific research that showed that these patients sometimes have even a worse prognosis. Like the death rate in them is like more than those who present with lung disease initially.
And why would that be? What would be going on with those patients? Would it be their immune response?
This is a question that probably my colleagues can answer better than me, but yeah, maybe. Probably, or maybe the route of getting the disease can affect the severity of the disease and how body is responding to it. Yeah.
Paula, do you have some thoughts about that?
Yeah, so where the virus goes in the body is kind of determined largely by which cells in the body express a receptor. It's called ACE2. That is what the virus, binds to. And certainly cells in the lung and the throat have this receptor. And that's why, when the virus gets into your nose and your nasal passages in your lung, it sort of, sets up house there. But there are other, tissues in the body that also have this. One of them, for example, is the kidney, and some patients do have kidney symptoms, and certainly in the GI tract. So I think that, that's where the virus can go. And in, you know, we're all different, and different people, it might sort of seed different organs to, you know, greater or larger extent. And then there's also just the general side effects that whenever you get a virus, you know, it doesn't just affect the place where it's replicating. You know, the body's immune system responds, it starts to churn out all these chemicals that are trying to fight the virus. And these are the things that give you the sort of the body-wide symptoms, the headache, the fever, all those horrible things that aren't just sort of focused in your lung, but they are a sign of your immune system fighting this virus.
Okay. And also too, I understand that, like you mentioned, we have those ACE2 receptors in our nasal passages. And is that perhaps one of the reasons why the loss of sense of smell is often a harbinger of COVID?
Yeah, I think that, which has become a very, you know, kind of very famous symptom. And I think we all go around, like every morning I sniff my coffee. I'm like, yeah, I'm okay today. You know? That's to do with, like, it's a consequence of the sort of inflammation, especially in the sort of the area where you are detecting smell, that it's not necessarily that the virus is infecting and kind of killing those cells, but it's causing inflammation. Things are swelling up, and the normal sensation and sensory detection of smell and the transmission of those signals is temporarily, we hope, sort of halted. So yeah, that's why that happens.
Okay, wow. Dr. Butler-Wu, I wanted to talk to you or ask you about testing. I feel like there's been a lot of confusion about what tests can and can't tell us. I mean, it's great that there are a lot of different tests out there, but there's so many different kinds. What would you like to, I mean, could you give us kind of just a primer on testing?
Sure. And so just by way of background, I'm a clinical microbiologist, so I direct clinical testing for COVID in a hospital lab. And so, yeah, I don't think we've ever had a time where there's been so much public discourse on testing for an infectious disease. So basically, when we think about a COVID test, the sort of standard test has been a PCR-based test. So this is basically looks for the RNA genome. So humans have DNA genomes. SARS-CoV-2 virus or COVID virus has an RNA genome. And so essentially what this does is a way to look for the genetic material from the virus. And so that's the testing that when we refer to that's, you know, been short nationally, that's sort of the go-to test. The other test that sort of emerged sort of early on, which I'm not going to spend too much time on, was the antibody test. You know, back in March or April, it was sort of, okay, we can all get our status and have this immunity passport. That's very much been disproven as an approach. So then the sort of third kind of testing that came along is an antigen test. And so rather than looking at the for the viral nucleic acid, the RNA, the genome itself, it basically looks for proteins from the virus. And so the advantage of this testing is that it's rapid. It can be easily deployed to places like, you know, that maybe don't have access to PCR in a rapid time frame, where the results come back in a day or two tops. And so there's some controversy as to its performance. We know that it is less sensitive than PCR. We know that there can be some issues with false positivity. It's been touted as a sort of a marker for infectiousness or contagiousness. I think there's still some controversy there, but I do think it's useful in terms of being able to get access to testing in places where folks don't have access to testing. And then I would say as of last night, there's now a fifth.
Uh-oh, she froze. There we go.
Of testing. So there's another method that just got approved yesterday that is known as a LAMP test, which is kind of like a PCR, still looks for the RNA from the virus, but is a little bit less sensitive than PCR.
Yeah, I'm gonna jump in and say as well, I think we've had some very good demonstrations of what Susan is saying about how inaccurate just relying on a rapid antigen test is, because it's my understanding that that's what, for example, the White House has been using to screen people on a daily basis. And we all know how well that's worked out in terms of being able to identify infected people and stop spread.
Yeah, I think it's really important to differentiate, though, between this is the first time that I can remember or that I'm aware of where we're talking about mass testing on patients where we they're asymptomatic, right? So all the antigen data is primarily based on using it as a diagnostic test method in patients who are symptomatic. And so what's being talked about is more like the performance in an asymptomatic patient population. So some folks have been looking at studies or programs that have been employed in Europe where they are talking about using rapid testing to essentially break transmission chains and get control of the virus. But the programs that have worked have not been that you just do it in your own house, like a pregnancy test whenever you want it. They've actually been implemented by the government, been associated with things like mask mandates and actually trained personnel from the military, etc., performing those tests. So I think we just have to be, I think there's a lot of false narrative around testing, in particular the idea that people can test themselves and then go off and go to Thanksgiving or go off and have dinner with their friends. And I think we have to be very, very careful about that. Testing is not a replacement for proper adherence to measures that we know work, like distancing and masking.
Dr. Butler, I'd like to go back just a teeny bit. Could you break down what those false, preconceptions or misinterpretations are about among the general public about how those tests work and how a person might use it in making Thanksgiving plans, but why that would not be the best way to go?
Sure. So I'll sort of maybe take that in two separate pieces. They're sort of overlapping. But the first is, in terms of what are misconceptions, I think there's this sort of false narrative that's out there that PCR is too sensitive and that there are false positives, meaning we're detecting it in people that don't really have the virus. And so it's important to understand that PCR is a false positive PCR result is very, very rare. And so really, if you're totally asymptomatic and you have a PCR positive, it could mean that you are in the early stages. It could also mean that you had COVID maybe a month ago and you're sort of on that tail end. So I think it's important to differentiate a true false positive result from the fact that you have a detection that may or may not correlate with you having symptoms. In terms of the second piece, which is sort of, how it's being used or misused, anytime you're tested, regardless of the method, it is a snapshot at that moment about whether you're able to detect either the RNA from the virus or the protein for the virus. And those are not, no test is perfect. And so that's why essentially using a test to decide I have a negative COVID status or I'm not infectious today, and then sort of eschewing all the other methods is dangerous. Like Dr. Cannon said, the president himself got COVID, even though every single person around him got tested on a daily basis with an antigen test, and prior to that with a nucleic acid amplification test. So I think we just have to be very careful. I think the problem is people want easy solutions, and there are no easy solutions. We have to put in the hard work, and we can't test our way to normalcy and to just carrying on with things. We're in the middle of a pandemic, and thankfully hope is on the horizon in terms of vaccines and such, but we have to continue to be careful.
Yeah, Susan, one of the things that people are now starting to talk about is the idea that when you combine testing with being in sort of quarantine, that it may be more useful to sort of, if you like, go into quarantine and test yourself at the end of it to make sure you weren't infected throughout that period, rather than, say, testing yourself on day one, getting a negative, and then going into quarantine after that. That, there's an advantage to testing at the end of your quarantine. And I guess it's the idea that if you were infected, but not, enough to show up on a test at the beginning of your quarantine, you've had a few days for the virus to kind of, I guess, build up a head of steam so that you now will be positive on a test. What do you think about that?
Yeah, obviously there was some nice examples during the summer of like summer camps and whatnot, where they sort of the bubble approach. But in reality, for people to quote unquote quarantine, you still have to go to the shops, you're still buying your, I think we have to be very clear about people have different definitions of what quarantining is. I think, they've certainly summer camps were able to pull it off where they did that. I think the sort of narrative now, though, that you can just test yourself and go on about your business, I think is dangerous. I think in some ways what you're describing is a little bit like what Slovakia has done, where they essentially didn't quite quarantine people, but if you didn't participate in that rapid testing program, you weren't allowed to leave your house at all. Right. I think it's an evolving science, but we have to be very careful to understand what tests can and cannot tell us, and that there is, every test has limitations.
And we know that Slovakia ain't going to work in the United States. So.
No, last time I checked, we can't even get people to wear masks, let alone tell them to not leave their houses unless they get a test that's administered by the government. So I think we have to be very careful about that narrative that rapid testing worked in Slovakia. The US is not Slovakia, and those measures would not be palatable probably in this country.
Dr. G, something I'm wondering about is, what is your workload right now in the hospital? I know that Southern California has been somewhat fortunate in not seeing the skyrocketing increases of COVID cases, but it is seeing some. I mean, we're back in the purple tier. In your role as a radiologist, is that something that you're experiencing at work?
Exactly. Well, I think few months ago we had a rapid spike, but fortunately because of like quarantine and those procedures, we had less cases. But unfortunately, over the last couple of weeks, we see that again the number of cases increasing, and a lot of these cases actually, as we discussed before, came with very non-specific symptoms. Actually, we find a lot of them incidentally, like they came for trauma. And incidentally, we find COVID-19 in the lung. I had a couple of cases who came in with car accidents, and incidentally, we found like COVID-19. So we see more cases, and as I said, a lot of these cases don't have a specific symptoms of COVID-19.
And some of that is basically we may be detecting people that maybe had it before, and then we're picking them up, and then also Dr. G, some of them may subsequently go on to develop different symptoms later on.
Yeah, exactly.
Let's see. Okay, I have a question. Do you guys have any sense of when regular people, not frontline people, might start getting the vaccine? And also, do we know whether it's safe for children?
I think rolling out of the vaccine is every time we get good news, and we've had good news today about the second release of data about the Pfizer vaccine. Every time we get good news and more good news, to me, mentally, it brings the date that regular people are going to be vaccinated closer and closer. It's going to come down to a sort of a supply and demand issue that, we have multiple different vaccines that have been developed, as well as the 2 RNA vaccines people may have heard about in the last few days from Pfizer and Moderna. We also have a different platform of vaccine being made by AstraZeneca and one by Johnson & Johnson. And they are also kind of ramping up and scaling up. So if all 4 of those sort of leading candidates look good, and they all get approval, we've got kind of like 4 big buckets of vaccine shots that we can give people. Now, clearly, the first people to get it, I think we all know how we should prioritize, healthcare workers, frontline workers, emergency workers, and then people with pre-existing conditions, older people, they're the people we want to protect first. But once we've got through that group of people, and I don't know how large it would be, then it becomes more available to the general public. So, my guess would be sort of probably, should I pick a date? February the 4th is when will be available. But I think it's going to get closer and closer depending on how many of these other vaccines are also available. And the data on children, I'm not aware specifically about children. I know they've been included in some of the trials. I don't know if either of you guys know. I haven't seen any published data about children yet. But no special reason to be concerned that they would behave any differently. I think one of the things that's exciting about the data that was released today from Pfizer is that older people, again, some of us are in that group already, but that's the group we kind of care about protecting. And sometimes older people don't respond as well to vaccines, like the flu vaccine, for example. But the Pfizer data says that they responded just as well to their RNA vaccine as people of, sort of younger age groups. So I think that's actually, to me, was some of the most exciting data that I saw today, because I was worried about that, quite honestly.
A random question that occurred to me is, some people who did get COVID and have recovered have antibodies. Will there be any antibody testing in order to, conserve vaccines for people who don't have any antibodies?
You mean the idea of pre-screening people and vaccinating you? I think you would just want to vaccinate everybody. As Susan said, the antibody tests aren't great.
Okay.
They have.
There are people, there are, other types of tests for sort of immunological readout, that are in the works and are being developed. I know there is a conversation, some people are thinking about, could you prioritize based on some sort of correlation with immunity, but there's nothing really that's available at this time, that's widely available and widely used, that would allow one to do that at this time. That it's such a rapidly moving target. Everything moves so quickly now with diagnostics. It's possible maybe by February 4th that we would have that, but at this time, not really.
Yeah, I think the other piece of good news we've heard in the last few days is I think everybody's heard about antibodies, and antibodies are one of the ways that your immune system develops weapons against a virus. So either when you get infected or when you get vaccinated, your body makes these antibodies that recognize and stick to the outside of the virus when it's in your body and stop it infecting you. But in addition, there's also this whole other branch of the immune system called T cells, which are just as important, if not sometimes more important, in allowing us to fight diseases. And although antibody levels sometimes can drop in people, even a few weeks after they've been infected, there's new data saying that the T cells kind of, stay strong and stay on guard. So I think increasingly we're getting more and more optimistic that people who've had COVID and people who get vaccinated will have a reasonable length of a protective immune response that should protect them. And, we'll see. And maybe in the future, we learn that you have to vaccinate people every 2 years or every 5 years to maintain that immunity. And, that would be great as well. Nice problem to have, an effective vaccine that only lasts a few years. I'll take that.
Yeah, there is a test now that's available that can look at T cell response specifically, but it's not something that's been widely integrated into clinical practice yet. So we kind of have to watch that space.
So we have a question from a viewer, and it is, how likely is COVID transmission on airplanes for flights that are 10 hours or more?
Do you want me to take that one? I've thought about this a lot. So airplanes are actually surprisingly safe. The downside is, of course, you are packed in next to people, so you're breaking the 6-foot rule. But airlines are enforcing people wearing masks. And what's really important is that the air handling in an airplane. Remember, we were talking earlier about the idea that if people are secreting virus, it's in the air around you. Airplanes recirculate and filter the air very rapidly. So actually it's extremely clean air. So what I say to people is, if I was going to be stuck on a plane for 10 hours, here's what I'd do. I'd get a good mask, and I'd probably wear a face shield or goggles as well, because we also have evidence that people who wear eyeglasses are less likely to get infected, which tells you the virus, may be getting in some cases through your eyes. So I'd put on my goggles, I'd put on my mask, I'd get on the plane, I'd turn on the air handling above me, the vents, so that I've got, air constantly moving things away from me. Of course, I'd want to have, a sweater and extra blankets, because, it'd be even colder than usual. And then I would try really hard kind of not to eat or drink, or to minimize how I was doing that. Certainly if I was going to eat, I wouldn't do it at the same time as my neighbors. Maybe we could, They eat one time and then I eat in the next hour. And if I'm going to drink, you know what? I'm going to take a straw with me. I'm going to stick it up under my mask and I'm going to do it like that. So there are ways, if you think it through, to keep protecting yourself. Also, if you go to the bathroom, keep your mask on. I know you might get in there and go, oh, thank God, take my mask off for a bit. No, that's a very small space. And, it's not great for air handling in there either. So I would keep my mask on. And then finally, just be aware that probably the most risky part of air travel is at the airport. So if you get to the airport early and you're eating or drinking or you're milling around and you're not maintaining social distance, that's going to be much more risky than when you're actually on the plane and everybody is focused on behaving well.
I will say, having flown, though, there's a lot of chin masking on planes.
Yes, they need to be up here.
I'm not sure what the thinking is on that. People think
maybe people who are mouth breathers, I don't know.
Okay, here is another question. What about COVID and pets? Can pets get it, or can you get it from your pet?
Yes. How widespread that is, we have no idea. But there have definitely been examples of dogs and cats being infected. So I think if you wanted to be overly cautious, I would say two things. First of all, if I've got a dog and I'm taking my dog for walks, maybe I don't have my dog interact with and sniff every single other dog it meets on the walk. Maybe I make my dog practice social distancing. And then I think if there is COVID in your family, if one member of the family is infected and they are isolating, again, maybe think about the pets. If the cat is sleeping with, your husband who's got COVID one night and then comes and sleeps with you, again, kind of unlikely, but we can't completely rule it out. So I think for that period, I would be like, I'm going to have the cat. It's almost like a divorce, isn't it? I get the pets while you're isolating, think about that. So not something I want people to be sort of, overly concerned about. But again, just, add it to the things that, we can do that will just add extra safety.
There is a great picture I've seen from 1918, and it's a family and they're all wearing their masks and they have a little mini mask on the cat.
Oh yeah, for the flu. Yeah,
that's back in 1918. So
I don't know what
masking pets yet, though.
I don't know what cat that is that would wear a mask. I would love to know.
Not mine.
So bringing us back to our original topic about things that we've learned, there's a couple of areas that we haven't talked too much about. One is the increasing evidence that masks do work and perhaps actually protect the wearer to a certain extent. And then we also have not talked about the racial disparities that have emerged among that show that Hispanics and Blacks get sick at a higher rate and also have severe complications at a higher rate. Who would like to go first? Paula?
I can do the masks. Sure. Okay. Yeah, I think, again, if you think about, remember this idea that you are breathing out the virus, it's a no-brainer that a mask is going to work. Lordy, putting a bandana, a scarf, anything that gets wet after you wear it tells you that what you are breathing out is being trapped and filtered. And so now, surgical masks, there are good quality masks that, again, when you wear them over your nose and your mouth will really stop a huge amount of any virus from an infected person getting out into the atmosphere. And likewise, again, I think this is common sense by now. If you yourself wear a mask, you are all, you're not being completely altruistic. You're also giving yourself some protection. You are filtering out air coming in. It's not perfect, not unless you were, an N95, but it's going to get rid of a lot and, trap it on your filters or on the outside. So I wear a mask to protect other people, but to protect me as well. It's a no-brainer for me. And then the rates you're talking about it, the racial disparities, I'm sure Susan and Ali can talk about this more, but certainly in Los Angeles, I think the Latino population, about 39% of LA County and 60% of all cases. And it likely reflects that a large number of that population are in frontline jobs. They don't have the luxury of staying at home and kind of ordering everything on Amazon. They're out there working. And also there's a greater tendency to live in multi-generational households with more people in more densely populated parts of the city, and more use of public transport. So all these factors, I think, increase the likelihood of you being exposed to COVID. But I think Ali probably has more insights into what's understood about the disparities in terms of the actual severity of the illness in the Latino and African American population.
But I think it's important to point out that all that COVID has done is reveal the disparities that have always existed.
Yeah.
When we think about mortality of infant mortality and maternal mortality amongst our Black citizens in this country. I mean, there have been disparities there for years that have been brought to the fore by this pandemic that really speak to the fact that these need to be tackled. Institutional and systemic racism has implications with respect to health disparities that are really evident now. Just with the mask piece, I think it's important to point out that in Asia, where mask wearing was really commonplace, there really have been less issues than we've seen here. I don't understand why masking is a political statement. It should not be. It is a hygiene issue. I think I read someone say that recently on the task force. It's a hygiene issue, and we should all be the same way we cover our cough and cover our sneezes. It's considered rude to cough in people's faces. This is an extension of that. So, sorry, Dr. G, if you want to.
Yeah, I totally agree with you. There is a disparity. We recently did a study on the use of imaging in the emergency department in the US. It was a systematic review, and we found that there is a disparity. Definitely, there is disparity out there. But specifically about COVID-19, speaking about COVID-19, we are currently running a study. Before having the final results, I can't give you stats, but I totally agree with you. There is disparity in the patient care probably to some level, and I would say maybe somehow it's because of different manifestations of the disease, because probably in different races, probably patients present to hospitals to get care like in different stages of the disease. Maybe some people present later compared to other people because of their insurance status or whatever. So I totally agree that there is some kind of disparity.
Yeah, I mean, one of the good things, Lee, is that this is recognized as something important. And so in the state of California, the metrics that are used to kind of determine which tier a different county is in and how well we are doing in our response to the coronavirus doesn't just look at what percentage of people overall in a county have COVID. It also has something called a sort of like an equity index that also makes sure that your county doesn't look good just because your wealthy neighborhoods have low levels of COVID, but you're seeing hot spots in your poorer neighborhoods. There's definitely a push from the governor's office to make sure that all the counties think about equity when we think about our response to COVID.
So I have a few more questions before we wind it down. So I'll just read through these. So is the current or winter surge in COVID-19 from the refusal to wear masks, or is it from poor ventilation? Should we open our windows more? And then I have another one. Would somebody test positive on a PCR test if they are in the incubation phase on, say, day 6 and end up being positive by day 12?
All right, I can take the surge and Susan can do the testing.
Okay.
Yeah. I mean, we're seeing a surge now. And, in Southern California, we can't blame it on cold weather and being indoors. It's going to be a combination of things, but it's just, I think we're all getting fatigued with COVID, and people are maybe letting their guard down a little bit in terms of distancing and wearing masks. And the problem is that once that starts, it's going up exponentially. So everybody recommitting now is what we need. And then additionally, as we move more indoors, I mean, again, we're lucky down here in Southern Cal. We can stay outdoors for a lot of things, and we can keep our windows open, especially on a day like today. So please take advantage of that for as long as you can.
I think in some ways that I just want to to address, there's, in terms of like conspiracy theory type stuff, there's this idea that this new wave is a case-demic, that's because you're just looking more for it. I think it's very important to point out that there is more COVID, there are more hospitalizations, there are portions of this country, and we will be there soon too if things don't change, where there are basically no open ICU beds or very close to being out of ICU beds. So yes, with more spread, we will detect more cases. And in turn, then after we detect the cases is when you will start to see, with a week or more delay, the increase in hospitalizations. So with respect to the question about testing, I think, Lee, the question was, if you were incubating, could you have a false negative PCR result? Is that the case?
Yeah, let's see. I think that's what they meant by it.
Yeah. So essentially, if we think about the pattern with which, when you become detectable by PCR, so on the day you're exposed, you are going to test negative. Like Dr. Cannon mentioned earlier, you kind of have to wait for the virus to start replicating in order to be able to detect it. And certainly if you've been exposed, your known exposure, typically getting tested at around 5 to 7 days is usually enough to allow the virus to be detected. But again, just on that negative result, you shouldn't assume you're not going to again get COVID. There's a reason there's up to a 14-day incubation period. So any test can be falsely negative. Certainly with PCR, one of the things that we see is that, on that sort of first day or two of symptoms, there are maybe 10 to 20% of people that will test falsely negative. We also see that as the virus progresses, it starts to be less detectable in your nasal passage and more detectable in your lungs, so with the sputum sample. So yeah, there is a pattern of positivity that we see as symptoms progress and as the infection throughout its time course. So for sure, if you're somebody who is symptomatic right now, there are very little other respiratory viruses circulating. So if you have a negative COVID test, you shouldn't, and you are symptomatic, there's a reason the CDC says that you should be, self-isolating or quarantining on the basis of time and looking at your symptoms, rather than using a test result as a free pass because of those issues.
Good point. Okay, I have one final question. This, I think, is for Paula. Are there any special concerns about long-term side effects from these RNA vaccines, such as maybe autoimmunity?
Yeah, so these RNA vaccines from Pfizer and Moderna, it's a completely new platform. We have very little experience using them, but oh my goodness, thank goodness we have them. Thank goodness they were, kind of in our arsenal. The concern with any vaccine is always you are trying to fool your immune system into thinking you've been infected by a virus, in this case, coronavirus. We always are concerned in case we do too good a job, if you like, and fool our immune system into doing something else as a side effect. I think what's been very exciting is that in the close to 100,000 people now between the two trials who've received these RNA vaccines, there's really been no serious side effects. The only side effects really have been kind of a little bit of fatigue, on the day of injection. So I think that's really exciting. A lot of technology and science has gone into making these RNA vaccines to make them safe, while at the same time, effective as well. So this is kind of what the science hopes for. And again, I think the data so far, 100,000 people is not a small number of people. And I'm personally very reassured by that. And again, I suppose come the 4th of February when I'm getting vaccinated, I think that's going to come back to haunt me. I would happily take either of those vaccines. They could give me one in each arm. That would be fine for me.
Well, on that note, we're going to say goodbye. Thank you so much for participating today, and thank you for our viewers for tuning in. So stay safe, everyone.
Thanks for listening. Be sure to subscribe to our podcast and visit us at podcasts.usc.edu.